Hello, we're rolling into another episode of the DRH Show. As usual, in each episode, I'll be talking to interesting people within psychology, mental health, and well-being. I'm very lucky today to have the president of the Canadian Psychological Association, Dr. Ian Nicholson. Thanks for joining me.
Happy to be here. Thank you.
It's great to have you here, Dr. Nicholson. Let's start off with you telling us your trajectory in life on how you became the president of the CPA.
Yes, I went to undergraduate and graduate school, master's and doctorate at Western University in London, Ontario. Started work at what was then Victoria Hospital, but then became London Health Sciences Centre in 1990. Have been working there for the most part since that time, and have been involved with the Canadian Psychological Association since the mid-90s. I started on the accreditation panel for the accreditation of doctoral and residency programs. After 6 years on that, I also moved on to the board of directors for the Canadian Psychological Association. After 6 years on the board, I was off for a while, but I did stay on the ethics committee for the Canadian Psychological Association. And then about a year and a half ago, was elected as president of the association. And my term is finishing at the end of this month.
Mm-hmm. Okay, so are we allowed to know the name of the person who's replacing you?
Yes, it's Dr. Kim Corrace. She is from the Royal Ottawa Hospital in Ottawa, Ontario.
Okay, so Dr. Nicholson, I suppose what I want to know is how are psychologists in Canada responding to the COVID-19 pandemic?
Oh, that's an excellent question. They're responding probably in two sets of patterns from an association standpoint. We have the National Association. We're developing we started with developing a series of fact sheets for people in the public on coping with COVID, as well as how to deal with having a children at home and trying to teach them at home, the understanding the psychological impact on frontline workers and information about that. So a variety of different fact sheets. We're also working with, as a national association, with the National Insuring Company for psychologists to assist psychologists to understand the insurance impacts on their independent practices of this work. We are working with national funding agencies for research to assist them to understand how psychology research can be through COVID and ensuring that the psychological and mental health aspects of the pandemic can be evaluated by people with strong training like psychologists. We're also lobbying government to get them to understand the mental health impacts of this pandemic. And we are developing webinars for Canadian psychologists. One is on how to deal with the impact on your clinical independent practice in these areas, as well as how to understand what's occurring with frontline workers. That's particularly important because as a national association, we set up a national group of psychologists from across the country who are willing to donate their time to be able to provide frontline and essential workers within the healthcare industry with the types of supports they need for their mental health. So they're donating their time. We've got this database now of almost 300 psychologists across the country who are willing to donate their time. Now, I mentioned that's occurring at the national level. In Canada, there's, which probably we'll talk about a bit later on, there's a strong division with the provinces. We have 10 provinces and 3 territories, and they have under the federal legislation that created Canada, the provinces and territories were given the power and authority over healthcare. And as a result, psychology is also very strongly represented at the provincial level. And the provincial associations also have been setting up similar networks. So, for example, the City of Toronto's liaising with the Ontario Psychological Association to support people in Toronto with mental health issues during the pandemic. So that's occurring at the association level. In terms of how it's affecting psychologists in the country, a very large percentage of our psychologists are probably working in 3 different areas. One are frontline workers in institutions. The ones in schools, there have been layoffs in certain cities of the school psychologists because children aren't attending school and won't be for the foreseeable future. We don't know when kids are going to go back to school, so they've been laid off from school boards. And we're certainly advocating for ensuring that they get the support they need during those times, in part because the mental health of children during this time is also being severely affected. We also have psychologists in hospitals who are really trying to look at new and innovative ways to be able to provide the care they can to Canadians through telehealth and trying to work on that through the hospital system. We also have researchers. Some research ground to a halt almost overnight as a result of some of the restrictions in the pandemics, universities closing, courses having to be taught online now, that during the middle of the course, having to stop and switch and make it an online course. So those are challenges for psychology educators and people who are going through training. When you have required training that you have to be going through, to suddenly not being allowed at the training sites because of the pandemic. It's been a couple of months now, not being allowed to have patients come in because hospitals have closed a lot of their ambulatory work, except for urgent and emergent care, and the impact that's having, as well as psychologists. The third group would be psychologists in private practice. There are a lot of people who are working in independent practice, and those restrictions on having people come into your office for one-on-one therapy, when that was pretty much closed down by the government, that has put a lot of psychologists doing massive changeovers in how they provide care, providing more video-based options and having to think about the ethical and legal issues relating to video therapy, for example. And so that has been a challenge. As a national association, we've been working to provide information to our members on how to best transition over to video-based care. But there's some things that were still very difficult, as I'm sure people understand, to be able to provide over video. It's very difficult, for example, to do in-depth neuropsychological assessments with testing or school assessments of children through video. So we're still trying to support people when patients start coming back to offices and coming back to institutions to best understand how they can meet the standards for distancing, meet the standards for cleaning and so on that would be required in these in a post-COVID world.
And clearly, as you've just explained, the CPA is at the forefront of managing the psychological needs of Canadians in light of the coronavirus. But of course, aside from being the president of the CPA, you're also the manager of the London Health Sciences Centre. So if you could just talk to us, what's the aim of the London Health Sciences Centre?
No, London Health Sciences Centre, I'm one of the managers there. There are a number of managers. And the London Health Sciences Centre is a acute care teaching hospital in London, Ontario. London, Ontario is a city of almost 400,000, serving a relatively large geographic area of closer to 1 million. And that's, it's about halfway, London, Ontario is about halfway between Toronto and Detroit. So it's the largest center between those two major cities. And London Health Sciences Centre is the acute care teaching hospital for that region. It has about 1,100 beds, includes a children's hospital. It has about 15,000 healthcare staff, physicians, nurses, as well as hundreds of trainees that go through every year. And I think we had last year about 800,000 ambulatory care visits throughout the entire hospital, about 165,000 visits to the emergency room, and about 55,000 patient admissions. So it's a large, very active, very diverse acute care teaching hospital serving the Southwest Ontario region of Canada. My role there is the manager of psychology, audiology, and speech language pathology, where I help just with the management aspect of running those three professions at the hospital. Audiology and speech language pathology in Canada are registered at the master's level, and the psychologists at an academic teaching hospital would be almost uniformly doctoral level providers.
And thank you for sharing to us the kind of work that you do for the London Health Sciences Centre. Clearly, you've been very busy with CPA, being an academic, and also managing that centre. But Dr. Nicholson, what's the most important thing you want the public to know about your research, about your clinical area?
I think one of the most important things is about the breadth of psychology. People tend to sometimes assume that psychology is just one-on-one counseling. And while that is an important part of the role of psychology, psychology is much, much more. And for example, at our hospital, we have about a third of my staff are in neuropsychology. And with neuropsychology at an academic teaching hospital, they are assessing patients, for example, for appropriateness for deep brain stimulation for Parkinson's disease. Because if they have any signs of an early dementia, they're not appropriate for that type of surgery. They're also responsible for surgery before epilepsy. They do a full neuropsychological assessment before epilepsy. As I like to say, before the neurosurgeons cut out a part of the brain, they want to know what it does. And that's really what the psychologists do in their assessments. So they've been actively involved in pre-surgical assessments of those patients for decades now at our hospital. We also have a neuropsychologist that only works with inpatient medical and psychiatric patients, doing neuropsychological assessments of those patients. So we have that large neuropsychology portion. And also about a third of the staff work in health psychology. For example, we have a psychologist who works with our epilepsy program. It's an interesting issue with epilepsy. There are two aspects of it that I find particularly interesting from a psychology standpoint. One is people will sometimes go their entire life with an identity of having epilepsy. That's a part of their being. And then finally they have surgery, the epilepsy is stopped, and they don't really appreciate that not only have they lost that major problem that was taking over their life, they've also lost part of their identity. They viewed themselves as a person with epilepsy for their entire life, and now they have to rethink who they are, and that can be a challenge. Also, one of the more interesting aspects of surgery for epilepsy is there are people who have non-neurological epileptic seizures, where they're having seizures, but they're not, it's not epilepsy, and they're often psychologically based. So we have a psychologist who works with those patients as well. We also have a psychologist who consults with the medical floors, helping people deal with medical issues in their beds. And that happens one person who does that with the adult population, there's a person who does it at the children's hospital. We have psychologists who works with juvenile diabetics, as part of that work is, getting kids to basically transition to looking after their own diabetes, and how difficult that can be for some families to give up the control of the child's diabetes to a teenager. Teenagers are teenagers, and it's very difficult sometimes to sort of appreciate that at some point they have to take responsibility for their own life and death healthcare, and that can be a challenge for parents and the teens. So we have a psychologist that works there. We have psychologists working with our pediatric oncology service. We have psychologists working with bariatric surgery service. So we have a lot of psychologists working in healthcare and working with medical patients and surgical patients. So that's part of the role of psychology at an acute care teaching hospital, as well as the mental health care that's there. And I think the last thing I'd like to point out is the value and importance of psychology and the broad training of psychology for program evaluation of mental health care programs that are being brought out. Psychologists often are the ones who are turned to develop these programs, to evaluate these programs, to train the staff of the programs, to really work at sort of getting psychology out there so other people can do the work and understand what needs to be done. So psychology is more than just individual one-on-one counseling. That's a part of what we do, certainly. But the profession is so much more than that. And part of my role over the last few decades has been getting people to understand the true breadth of what our profession can offer, particularly in the acute care teaching hospital.
Mm-hmm. I can see the similarity of your message to what the BPS, the British Psychological Society, is doing here in the UK, and they're also trying to communicate to the members that there's actually a wide breadth and wide options if you want to get into psychology. And yeah, just like what you've said, it's not just all about counseling, but there's also a clinical aspect, and there's also health psychology. Now, Dr. Nicholson, what I'd like to ask you is there a particular publication or a particular individual who has the greatest influence on your work?
That's interesting. I think the one person that I've only met a couple of times, I had a number of conversations with him over the phone. He was exceptionally generous to me, was a psychologist in Minnesota by the name of Paul Meehl. Paul Meehl worked, part of his doctoral work was on the original MMPI. And his work on statistical versus clinical prediction really set the basis for the research that's gone on in that for decades now. About, as people are likely aware, the issue there being a lot of psychologists like to go with their gut because they know what's best, as opposed to what, and it became pretty clear that actually there are a lot of things that affect what our gut says that may not be totally accurate. There are a number of biases that we're prone to as much as anybody else. So is it better to go with truly statistical prediction on this? Mm-hmm. So something that we've looked at as a profession for decades now, and in part that's because of the work of Paul Meehl back in the 1950s. And he continued to really push the issue that as a clinician, you need to think about the data and be a data-driven science practitioner group. And my doctoral work back in the 80s was on trying to better understand the symptomatology of schizophrenia, whether there were actually subgroups of schizophrenia, or whether the symptoms were better to be thought of as continuums and people being placed in different aspects of symptomatology continuums. And to do that, you needed to have a statistical analysis of the symptomatology about whether it was truly one or two groups that you were seeing in the data, whether the curves were bimodal or unimodal. And he came up with statistical techniques for that. And I just gave him a call one day, and he spent enormous amounts of time with me on the phone. However, beyond just the content of the information that Paul Meal shared with me, I think one of the main things he taught me was the incredible importance and value of sharing and supporting colleagues. And I think that's part of what led me to work with the Canadian Psychological Association over the years, is to recognize that we truly are a community of a profession, and we're not just individuals. And the more we can support one another, the more we can advise and guide people, particularly people more junior than us, the better we will be off as a community. There's not very much in it for us at an individual level, but there's enormous amounts that come from the community aspects and supporting the community. I mean, he was a senior, highly respected member of the profession back in the 80s when he was helping me. And he had no reason to help me other than to help me and to support me and to guide me. And it was incredibly necessary for me, incredibly valuable. And as I say, beyond the content, it really helped me to truly understand that. The literature in recent years has tended to use the term communitarian for this type of model. And I think I really do embrace that idea that the more we can recognize that we're part of a professional community, and the more we can support that professional community, the more we can grow and develop, and the stronger we'll all be when the community is stronger.
And I just love what you said about, that particular individual who supported you. And in essence, you're actually supporting my YouTube channel. And I'm really grateful that you're taking your time, to talk to the listeners and to the audience. And just like what you've said, it's a way of trying to, to help support the community, the psychological community. And I'm really grateful for you for taking the time. Now, I just like to touch upon more about what you've, what the nature of your work within speech language pathology. Dr. Nicholson, within that area, what should we learn about speech language pathology in relation to human behavior?
Well, it's an interesting question. I think that I have to admit, and I will be honest about this, that even though my wife is a speech language pathologist who's worked in the schools for decades, recently retired, that I did not have this full grasp as to what the role of speech language pathology was in the acute care teaching hospital. And the majority of the work speech language pathology does at the hospital, at our hospital at least, are swallowing assessments for patients, for example, after head and neck cancer surgery, helping them and the medical team understand what needs to be done to assist this person to swallow again, which is a basic need that we have, to assist them in being able to work with that. They also speech language pathologists who work with the vocal function lab, a lot of work with neurology services. They're an important part, and actually mandated by our government to be a part of our stroke team, to assist not only in swallowing assessments, but also with language assessments for patients after stroke, and the team getting to have a better understanding as to what's truly going on in terms of their patient's capacity to communicate with the rest of the team. And that communication aspect is vitally important. They also have a wonderful project they're working on in the hospital, an iPad project, where they have, they set in certain cases for patients who have difficulty speaking, perhaps due to Guillain-Barré syndrome or some other problem, they will set up an iPad and the use of my technology eye tracking technology for people to be able to use the iPad to communicate with their healthcare team and with their families during those particularly challenging times while they're in hospital. But beyond just the sort of day-to-day and vitally important clinical work that's done by our speech language pathologists, I think for me, it really has reinforced something I've grown to appreciate much more over the last 10 or 15 years, which is that the importance and the value of all the healthcare professions and all of what they bring. In the past, I've been a manager of social work. I'm also now currently the manager of audiology. And one of the most important aspects, and I think it's one of the problems we actually have as a profession in psychology, is the capacity to be able to work with healthcare teams. Psychology, I often joke that we're trained in silos to work on teams. And if we really want to do the best we can for our patients, we need to be able to understand and appreciate the work that's done by the other health professions that we're working with. And too often, psychology, unfortunately, is seen almost as either isolated off on their own and not working with the rest of the team, or when they do come in to work with the team, they're sometimes seen as a bull in a china shop, not recognizing and appreciating the value that's added by the other healthcare professions as independent healthcare professionals. And one thing that I know I've been advocating for, as others have in the profession, is what's referred to as interprofessional education. The model that groups really need to learn to work with one another. It doesn't happen naturally. One of the things you often deal with as a manager are difficulties on teams because people just don't really play well with one another. And the more we can learn and train people through their graduate training about what is the role of psychology on a healthcare team, the role of psychology working with occupational therapy, working with medicine, working with speech language pathology, the more we can learn to train people to work together in interprofessional care models, the more we can be successful in providing psychology services to our patients when we have to either consult with teams or when we're actually placed as members of teams. Healthcare is too important to be left to individual providers. They really need to be working together for our care, and we need to be a part of that. And to be a part of it, we need to be educated to work as best we can with a range of different healthcare teams.
And while I was doing my research to you prior to this interview, I also discovered that you work with people struggling with anxiety. So one thing that I want to ask you is, how can we tell if anxiety is interfering with our daily lives?
Oh, and that's an excellent question. There are some very common standards that are used. For example, is it affecting your sleep? If you go to bed worrying about something and you're waking up during the night worrying about something, that lessens your preparedness for the capacity to be able to deal with the next day. To see if there's an increase in, how often want of another phrase, your bad habits. They may be things that you that don't have a long-term impact on you, but sometimes they are. It might be an increase in drug use, both prescription or illicit drugs. It might be an increased use of smoking or alcohol. There are a wide range of different things that can occur in the way that from anxiety. It could be an increase in emotional lability or more reacting to things. I have a staff member now who is quite concerned about a variety of things going on due to COVID, and you can, the team can see the impact this is having on her because she is more reactive to things than she would have been in the. So that sort of emotional reactivity is another common sign for anxiety. And that related to that is just lack of patience. You find yourself just giving up on things, just walking away, just not having the time to put up with stuff anymore. That's a very common reaction that people have during increased anxiety. Does it affect you? I mentioned sleep. Does it affect your eating? Or you find yourself a nervous eater, for example, putting weight on just because your eating calms you down? There are a wide range of different things, and most people sort of know what individually for them they tend to turn to when they get anxious, the symptoms they display. But during these times, we have to keep more of an eye out for those things, and we have to, well, for want of another phrase, we have to look after ourselves better, because there are a lot more challenges put on us during the pandemic and the restrictions that are placed on us, and making time to ensure we're properly looking after ourselves is probably one of the most valuable things we can do to get through this.
So what advice would you give to young people who are struggling with their mental health and well-being? I suppose you could also add some advice on, especially during the lockdown. I've read a few articles that they're saying that the lockdown could also trigger a number of mental health issues. So what advice would you give to, people who are already experiencing challenges with their mental health?
No, I mean, that's an excellent point, and we're certainly finding that clinically at the hospital. For a lot of people during the pandemic, there was this sense that it was like being hit by a brick or something. You just just the world suddenly changed in 2 or 3 weeks. Everything was different, and the focus was often more on what was happening around. But in the last month or so, things have begun to get into another rhythm of sorts. People are beginning to sort of learn to live their lives in these areas. And mental health issues are becoming more and more pressured during these times. So there are a handful of things people can do to sort of cope with the stresses of this pandemic, whether they have mental health issues or not. One of them is to certainly reach out more to people. As we're doing this podcast right now, I've had more than one person say to me, they're not sure how they would have gotten through this if this had occurred 2 years ago. But now we do have this technology that does allow us to reach out for people. It's not the same as actually being in the room with the person, but it is a lot better than it would be just if we didn't have this type of technology. So that there is that one advantage, reaching out to people. Another one is trying to get back into habits that are healthy. During the hit of this pandemic, a lot of people sort of lost a lot of their habits. They weren't able to do things like going to the gym and so on that they might have otherwise done. You need to develop new habits. And that takes work to develop a habit. Psychologists know that it's vitally important to really spend your time developing the new habits, really working at them, they become natural. But so the more you can work at developing healthier habits, like finding ways to exercise, to relax, the better it will be for your health. For people with mental health concerns, if they have linkages with mental health providers, to reach out to them. A lot of them were taken aback by all of this as well, and they've had to work at changing how they provide care But now there are a lot of avenues available to people that just weren't available a couple of months ago. And they may not be aware of them. So try to reach out to some mental health agencies or mental health providers to see what might be available to them. And as always, there are emergency services, crisis call lines, and those continue to be available for people. One thing I've heard, and I think I need to just make a special point of, if you don't mind, and that is that a lot of people are afraid to go to emergency rooms. They think they're filled with COVID patients, and to walk into an emergency room is to walk into a center for COVID. And I really need to push the point that that is not the case. If you need to go to the emergency room, you need to go to the emergency room. And that includes for mental health care purposes. There are, as I say, other strategies out there. There are crisis lines, other mental health drop-in centers that might still be available in your region. But emergency rooms are spending an enormous amount of time and energy to ensure that whoever goes there for whatever their emergency is, whether it is a heart attack, whether it is a stroke, whether it is some bowel obstruction, if they have a clinical emergency, including mental health emergencies, you need to be able to go to your emergency room. Do not avoid the emergency room. They're set up to keep you safe and protected during this time. And so if you have a true mental health emergency that you need to go to a hospital emergency room, don't let COVID stop you. They're set up to be able to keep you safe if you were to go into one.
Now, Dr. Nicholson, I'd like to go back to your role with the CPA. So I'd like to find out what's the focus of CPA in 2020, but I imagine a lot of it would be dominated by COVID-19. But what are other focus of the Canadian Psychological Association for this year?
In general, the Canadian Psychological Association sees itself as being organized under three pillars. The first one is the obvious one we've been talking about mostly here, and that's clinical practice. It involves training for some aspects of training for clinical practice, continuing education, as well as supporting research in that area. So clinical practice is one of the primary areas. That includes, for example, insurance for providers and we set the ethics standards for the profession through the Canadian Psychological Association Code of Ethics. So we have that sort of practice-oriented aspect. The second pillar is related to research, supporting clinical and non-clinical researchers in psychology. As you know, psychology is an incredibly broad profession. So somebody who does animal research, someone who does education research, someone who does personality research, someone who does clinical neuroscience research, they're all within psychology, and we need to be a big tent to support a wide range of different psychology researchers. And so that's the second leg of that. The third leg is training, working with schools to teach psychology, to set standards for training, set standards for continuing education, to provide continuing education opportunities through the association. And so we've got the three pillars as we talk about it, practice, research, and education training. So that guides the work of the association. Every few years we redevelop our strategic plan, as most large organizations do. The one big aspect of the association, though, and I've come to learn the legal aspects of it in the last few months, is sort of a national convention where we bring hundreds of psychologists from across the country coming to one place to really sort of work, learn from one another, to develop the relationships that go outside of that meeting place to go on for the rest of the year.
And by the way, does CPA accept international members? I mean, like, even if you don't live in Canada, can you become a member of CPA?
I would have to double check on that. I believe there are certainly CPA members living in other countries. They're really, I don't think the membership is based so much on nationality as much as meeting the standards for becoming a member. We also have affiliates who may not sort of meet membership status, but we do have affiliates who still get a wide range of the access to journals and newsletters, and they just can't vote, for example, one of the limitations of being an affiliate. So there are different various levels, and we do have a number of international members. So I can't just sort of say somebody can join. There are membership rules for the various levels within the organization. Now, the convention, one thing I'll do mention is, and it's amazing how many conventions are in the spring, and the work that goes involved not only in developing a convention, but also canceling a convention. To cancel a national convention where you've got hundreds of people who've got research papers accepted, posters, they've all been vetted and been accepted, and people are expecting to come and present them. And suddenly you just have to cancel a convention. You have to negotiate with the hotel and the convention center. The conventions are very large and expensive activities, and it takes a lot of work, and our CPA staff have done phenomenal work trying to minimize the losses that occur from a convention and the impact on the people who are planning to come to the convention, particularly our students who find the convention exceptionally valuable way to network. But we are working, and just yesterday, I think, had a board vote to approve some aspects of the convention being done virtually. So virtual poster session, for example, virtual talks that are going to be given. So we're working on making that available to members as another way to try to share the information that's usually shared within the profession in the country at a national convention. So as you're right, COVID did take a lot of the energy out of the room in terms of all the things we're going to be working on. And that was, one was that convention. It's surprising just how vitally important it is to a national identity to have that sort of national convention. I know there's one in Britain as well. And just imagine that sort of being stopped pretty much on a dime. And that's a loss to the profession to lose the convention like that.
And I could also, I could also understand that because I also organize conferences, and yeah, a lot of things has been disrupted. Just last year, I organized a conference in Malaysia, and I'm planning to organize one now in Thailand, and all my plans have been disrupted. But carry on with what you're saying, Dr. Nicholson.
No, I was going to say the last thing that I certainly was really wanting to work on personally as president over the next, during the last few months, and would be focused on my presidential address at the convention, would have been on psychology's relation with our First Nations. As a country, we have done particularly badly with our First Nations people since coming over and taking over the land in Canada. One of the worst aspects was what is been referred to as residential schools. These schools were set up, run by the churches, working with the government across the country for several decades, going into the 1970s. And children were taken from their parents and taken to be trained and educated by these religious groups in places far away, and as once said, basically to take the Indian out of the Indian. And that was a tragedy of epic proportions within our country. And there have been a number of different aspects of just how that has rolled out across our country over the decades, the impacts of that, the term genocide has been used to describe it as cultural genocide for our First Nations peoples, and the recognition of the harm that that has caused for First Nations. And psychology did have a role in that in terms of our assessments, for example, not really being appropriate, but nonetheless being used with Native children to indicate that because they weren't doing well enough on our tests that were normed on nice European children of European background, that there was obviously something wrong with these children. And those sorts of inappropriate by psychologists in generations past contributed to that very large-scale problem that our country is really just coming to grips with now. As well, along with that, one of the other things we've found is that First Nations peoples don't trust our profession, and I can't blame them for just how our profession has worked with First Nations peoples over the years, and that has led to very few members of our profession being First Nations. I think the number that is commonly used is that there are a dozen registered psychologists out of 18,000 in the country who are First Nation. Some people say, oh, that's low. I know there are probably at least 2 dozen. 2 dozen is still absurdly low, and it really reflects just how poorly we as a profession have been treating our First Nations people, and how we are really not making it easy for them compared to most other communities within our country to get a psychology education and become a member of the profession. And as I say, that I was going to be speaking on that in my presidential address. We have a working group for our association that is working on trying to redress some of these problems. And we are really trying to increase our appreciation for the impact we've had on our First Nations peoples by our professions, and what we can do to rectify those decades-long problems.
Clearly, it's been a very dynamic and busy times for the CPA this year. Now, I'll move on to the next question, Dr. Nicholson, and I always ask this to all of my guests. What's one thing about mental health or one thing about psychology that you think we should be talking more about?
That's an excellent question. For me, the issue is around stigma. We still, whether we like to think about it or not, often think of our patients, those we care for, our clients, as broken, perhaps. And when we tend to think of people that way, we tend to think of them as somehow lesser, and that they need us to be able to pull themselves up, and we are in a better place for them. But we have as much to learn from the people we work with as we have to give them. We're placed in a very unique place within society, and we have to be able to call out stigma when we see it. We need to be able to support people who are being stigmatized, and to put mental health as being a part of health. Mental health, there is no health without mental health. And the more we can promote mental health as just being a part of our regular health care, the less stigma that'll come from it. Decades ago, cancer wasn't even, you didn't even use the word cancer. You talked about the big C, and or you talked about some other issues, but if someone had cancer, it was something that would be hidden away, and that's certainly not the case anymore. But mental health is still something people keep hidden. And I've often said that from the clients that I serve, I'm one of their biggest secrets, because getting treated for their problems is a shame to them, and they want to keep that hidden as possible. There's still a number of ways that can play out in our society. People with mental health care issues perhaps having more difficulty in getting work because they've got a mental health issue. People afraid to apply for certain types of work because they might do a background check and find they have a mental health history, and they don't want that to get out. That shame that comes from the stigma attached to mental health is really causing people not to access mental health. For me, one of the more interesting aspects of it is the more we destigmatize mental health, the more people want to access mental health services, the more widespread we realize those issues truly are compared to what we previously understood them to be, and the more need there is for the mental health services. So as a profession, the more we destigmatize mental health, the more need there is for our service. So we really need to get people to understand that mental health is not to be hidden. It needs to be brought out so that everybody can understand and have true health, which includes mental health.
Yeah, and I think the way we could achieve that is we should have a collective effort, not just from the associations like the CPA, but also with mental health professionals and also with the government. And yeah, we can come up with like a coherent plan to address the stigma. And that's really a lovely message coming from you, Dr. Nicholson. Now, what I'd like to find out is what's in the pipeline. Do you have any upcoming book, project, or webinar? You mentioned something earlier about webinar. So if you could just inform us any upcoming webinars that people outside of Canada could take part.
I don't have any in particular. However, the association, we are continually working and developing things for the public that are on our website, a number of fact sheets that can be used. We've also written them in ways that can be printed off by mental health care providers to be able to give to their patients or put in their waiting rooms. We have a variety of online educational opportunities available through the Canadian Psychological Associations beyond the ones that we've just developed around COVID. A lot of programs that are available to psychologists and other mental health care providers. The one thing I am particularly wanting to push in the next while is we had a training summit in Montreal for Canadian psychology, and it was the first one we really had dedicated just to training for over 50 years. And it really sort of aimed at trying to determine the goalposts we should be working towards for the next 50 years for psychology training in Canada. And we're just putting that material together in the last number of months, and we really have to sort of work on that. We've got, I think we brought 65 people from a variety of different aspects of psychology, a variety of different aspects of training and practice and regulation of the profession, and brought them together to Montreal for 3 days to develop sort of the blueprint for training. And they came up with dozens and dozens of recommendations that were agreed to by unanimous. Everyone was, it wasn't unanimous agreement on them all, sorry, but all of them were passed, all these recommendations, and they fall into 5 categories. One looking at just the basic standards and models of training and what should that basic model be. and how should we be developing that over the next year. And for example, in training for the profession, we've moved away from a model in recent, for most of the career of our profession, of training being we have to make people do a certain number of things. But what we've learned is that just because you make somebody do something, see a certain number of patients, do a certain number of reports, do a certain number of tests, that doesn't mean they're actually good at it by the time they're done. They're not necessarily competent. And the whole profession has been moving towards a competency-based model. So we need to adjust our training to be a competency-based model. So that's one aspect, is models of training for the profession. The other one is the recognition that supervision is a competence. It's something that we need to learn to do. And too often in our profession, we've tended to assume we can supervise people doing things because we were supervised ourselves, therefore we know how to do it. And that was the main training we got in supervision, was having been supervised. And now there are more courses being developed, there are workshops, continuing education, there are standards being developed for supervision, models of supervision. And so we really need to embed training for supervision throughout our career, and recognizing that supervision is actually a competence and not just an activity that we undergo. The third one is looking after, within our training, to recognize that our training has really not looked after the needs, as I mentioned before, of our First Nations people, but also other groups within our society that we have really done very bad work on, from an equality, diversity, and inclusivity model. And how do we bring those models into our training, and bring those people to develop those models from those groups, that using an inclusivity model to really develop our training so it's truly open for as many people as possible. We as a profession, unfortunately, tend to skew towards certain groups that tend to be more dominant in our profession, in our countries. So we really need to work more on that and develop that into our training. The fourth area was, and I think what's happening here today is part of this, is the recognition of technology and how that really moving in the profession. And I am struck by how our profession has been dramatically moving towards video therapy in the last 2 or 3 months as a result of all of what's happening. But are we actually training people in it? And it's similar to what we do when we're sitting with a person, but it's not the same. And people are, do we actually train students on how to sit in front of an iPad and work with a client as opposed to sitting in the room? And how do we train them differently? So we have to work on technology and how that relates to practice and how we train people for that. And that's, once again, the fourth of the 5 for that we're working on. And the fifth, something I alluded to before as well, which is about interprofessional education, and that we need to move more and more towards models of collaborative practice. And how do we train people towards collaborative practice, because we've been training them for individual practice now for decades. So this conference we had in Montreal, the Education Summit, was about this time last year, and it really aimed at trying to set the goalposts for where our training should be over the next 50 years. We've got dozens of recommendations that came from that, and we're just beginning on the process of trying to roll those suggestions out for the country. And when I finish my presidential year, that'll be one of the areas of focus for me. We'll be trying to work with the various stakeholder groups to see what we can best do to move these recommendations forward.
And Dr. Nicholson, could you recommend us a good psychology book?
The one psychology book I keep recommending people read is Thinking Fast and Slow. Daniel Kahneman's book, And it's, I think we as psychologists do like to point to Daniel Kahneman as one of the very few psychologists to get a Nobel Prize. And I tend to think of the book as being parts. The first part really goes through the cognitive psychology literature on what he refers to as fast and slow thinking. I was trained to think of it as automatic and effortful thinking, but getting people to really understand that. And I find that a wonderful way to get to truly understand not only how our clients think, but also how we think and the biases that affect the way we think about the world and our clients and ourselves. And then the second half sort of goes through all of that research, and then then the second half relates more to his Nobel Prize work, which is how that relates to behavioral economics, and really shows how psychology has reshaped our understanding of economics in the last number of years. So, and that's what he won his Nobel Prize for, was getting people to understand that the old economic model of the rational man is an interesting model, but man is not rational. And his work really just shows how irrational we are and predictable we are that way. And the book really summarizes all that cognitive psychology research quite well, and its application to life. And in the second half, how it really impacts economics and our own individual economic decision making. So it's a wonderful book, Thinking Fast and Slow by Daniel Kahneman.
Okay. I'll definitely put that on the description box, so for those who are interested to have a look or read that book, they can buy it. And this question, I'll go a bit personal. Dr. Nicholson, what other interests do you have other than psychology?
It's fascinating because my son once, he told me that he was with his friends, and they were all talking about their parents' hobbies.
Mm-hmm.
And my son came to the realization that my hobby is psychology. And a lot of the extra work that I do, just for interest's sake, tends to be psychology related. So that was kind of interesting when my son came to that realization, and I learned from my son, which was interesting.
Brilliant. And finally, Dr. Nicholson, where can we learn more about you?
Really, I think for me right now, when I'm thinking of talking to you right now, I think I'm seeing myself more as a representative of the Canadian Psychological Association as its president. And I think the best place to get information that I would like to point people to is not any information about me, because I'm just one person. I think the Canadian Psychological Association, and for that, it's just their website. There's a huge amount of information on there about psychology that would be useful for a range of different people and outside of well, and that's www.cpa.ca.
I'll definitely put that on the description box, Dr. Nicholson. Well, it's been an insightful conversation with you. I think we have to wrap up now. I am really grateful that you took time to share your time and expertise, and I look forward to hearing more about your work. Thank you.
Thank you very much. It's been a delight.